What I'm going to focus on today, though, is what happens at the initiation of the disease process. And up in red are rheumatoid factors and ACPA. And that is actually meant to indicate that these are circulating factors, and I will actually not spend any time talking about synovitis, because what I'm going to talk about is a different point in the disease process that I think, for many reasons, has its own immunologic basis. I'll start, though, with a sort of a case presentation, which was very striking to me and points out that in some ways what I'm going to talk about is really a generational change, similar to the generational change that I had when I was an intern at the Barnes Hospital, and somebody would show up with a heart attack and we'd do our best to take care of them, put them at bed rest for a long time, send them home. And of course now there's a whole different way that we assess cardiovascular risk. So if you have on the left there a 55-year-old male who had a family history, comes in and asks you, what about my risk of this? Smokes, has the rest of the history and biomarkers as shown in the lower left, and comes in and asks you with this kind of profile, what's my risk of getting an angina, MI, coronary death within the next 5 years? Here's the answer, next 10 years, and why is this important? Because now, of course, we think very much about risk factor modification and prevention goals, and one can actually go online and figure out what this is and go on statins and different ways of modifying future risk. Of course, as that evolved, up until very recently, and perhaps even now, you come in with a different scenario. 30-year-old female, mother has had rheumatoid arthritis at the age of 45. She, like everyone, and Ian mentioned this, well, I get rheumatoid arthritis. Uses birth control pills, doesn't smoke, has vague joint symptoms. Almost everybody does, in fact, as we've started to study this, but has no radiographic or clinical findings of joint disease. Even the ultrasound is normal, but down here has a very worrisome, if you will, genetic background, elevation of biomarkers. And now the question is, what do you do with her? What's this risk? So this is going to be our first audience response. And actually, this is a survey that we're taking going around the country to try to understand what happens now. Do you tell this woman to come back every 6 months to be checked up? Do you start hydroxychloroquine because of this? Do you tell her to come back with symptoms? Do you start methotrexate, take sort of a Dutch approach, plan on 1 year? Or do you get very aggressive and give a single dose of Rituxan because you want to wipe this disease out? So let's see what happens. Please vote. Very interesting. Okay, so let's see where you fit into this, this scenario. So it kind of goes from top to the bottom. So what I'm going to talk about today is how we think about this today and hopefully how we think about this tomorrow. Okay, so here is SERA also, founded in 2002. So I think this is SERA 1, and the Scottish is SERA 2, but we'll debate that over dinner tonight. So this is the umbrella under which the studies in Colorado and with collaborators now around the world have been undertaken. They're basic science studies that I'll just summarize by referencing a couple of the papers that we've done. Basically, the idea with these studies and mouse models has been to prove to ourselves that the anti-cyclic, anti-citrullinated peptide protein antibody response is pathogenic, and that pads that are involved in creating these epitopes could be a very interesting therapeutic target, and the pathogenicity is both with the antibodies as well as with T cells. It sort of underpinned our interest in studying these in the preclinical disease state. What I'm going to focus on today, though, are the clinical studies and translational studies that we've been working on in this particular area. So the first thing that one has to do is start with definition. So the European groups, the EULAR, has really, I think, helped a lot here in terms of trying to understand how we define this. And they have a proposed terminology which takes into account multiple states, if you will, in this at-risk population. Now, of course, out here, what Ian talked about predominantly was rheumatoid arthritis, but prior to that, there's a genetic risk, environmental factors, systemic autoimmunity, arthralgia, unclassified arthritis, and rheumatoid arthritis. And of course, this is not unidirectional. There's often individuals will go from one to the other. Sometimes they'll skip various stages. But I think it's a useful way to think about the disease. And from the standpoint of what we're doing in the SERA cohort is to really emphasize that what we're focusing on predominantly here are risk, environment, systemic autoimmunity, how that occurs. As we go forward in our studies, of course, we are starting to see individuals transition from this state to that state, and I think the challenge for the field right now is to interlink what one sees in the active disease with what one sees in at-risk populations and understand the relationships, interrelationships, and as I think the differences, if you will, between these two disease states. What we've done then in SERA that I'll emphasize today are to go through epidemiology, talk about some of the systemic immune dysregulation, tell you about how we're looking at what we believe now to be the origins of this disease ultimately, which is dysregulation at mucosal surfaces. I won't spend much time talking about the genetics. So far, this has not been a particularly important part of our studies, but we, of course, anticipate as we understand more about biomarkers and evolution that this will also become much more revealed. So I'll talk about the natural history of seropositive rheumatoid arthritis, talk about something that we've been increasingly working on is intensive phenotyping of these individuals, what we call deep phenotyping, the effect of environmental exposures as we understand them, go through the data on the mucosal origins hypothesis, and then spend the last several minutes talking about emerging opportunities in RA prevention, which we think are really have the potential to change the field substantially. The first study I'll just review has been published. This is an Army-Navy serum repository review. This is a massive serum repository that we pay for as part of the management and follow-up of military personnel. Working with collaborators at Walter Reed, we took out 83 individuals who had developed RA and then went back and looked at serially stored preclinical serum and came up and published several studies that largely mirrored what was done in Europe using blood bank resources with single time point prior blood draws. And there are a couple of points I wanted to make from this. This is a collaborative study with Bill Robinson's group. This is Jeremy Sokolov, whom Ian referenced. And this is looking at days relative to the diagnosis and looking now at a whole series of peptide targets, citrullinated peptide targets over this period of time. And what one sees is clear evidence of epitope spreading initiating many years prior. We can see some individuals with antibodies prior to 10 years. And you see this evolution and epitope spreading over time. Spent a lot of time trying to figure out what is the original sin, the concept of an initial break-in tolerance to a single peptide or perhaps a single pathogen that drives a single peptide that then spreads. And I'd have to say, despite a lot of work and a lot of bioinformatic work, we still don't see that there is a single peptide specificity that is either necessary or sufficient to drive this kind of a response. We were initially confused by that, but as I come back to this at the end, I think you'll see why we think this disease evolves in that way. Now, of course, you also see prior to this period rheumatoid factor and anti-CCP2 or 3 or 3.1 antibodies evolve. There are other antibody systems that we've also been working to try to understand, including the CAR-P using either fetal calf serum or fibrinogen as targets. And what one also can see is prior to clinical onset, one can see the emergence of these types of autoantibodies. However, I would have to say that so far we've been unable to find any that are more informative during this early period of time, including looking at individuals who eventually are seronegative. And so far, rheumatoid factor and various types of the ACPAs are the ones that are really informative for us. I love this slide. This is a slide given to me by Bill Robinson. I think when we saw this slide several years ago, it really pointed out to us the challenge and the opportunity going ahead of us. This is these same kinds of samples, the serial preclinical, timing serial match samples, a bunch of the peptides, and now a series of cytokines and chemokines that were measured by Luminex. What, of course, is striking here, to me at least, is that if you look many years prior with either the antibodies or the cytokines, there are clear elevations and distinct from the matched controls. And this started for the first time to give us this sense that in this preclinical period of time, there was a massive, to us, amount of immune dysregulation that one could see in that period of time, even though there was not evidence of arthritis and there was not evidence of illness, if you will, in these individuals. Now, whether they're ill or not is still, or how they're ill can be looked at in a couple of different ways. I'll talk a lot about our prospective studies, but this is another way of looking at a very interesting work study published several years ago, looking at days with sick leave in Sweden over time. This is 1 year, 2 year, and quarters. And what one can see is prior to diagnosis, and from this particular study, there was a fair amount of synovitis for several months prior to this, as I understand. One did see this sort of mixed picture, if you will. Certainly in years 3 and beyond that, there was not a difference in days with sick leave. As you got into the second and mostly in the 1 year prior to diagnosis, there was evidence of illness that at the period of time was ill-defined in terms of its origin. But I think the important aspect is there is a period of time out here that it still appears to be asymptomatic and a very, as yet, not well understood transition period. Now, this is in your in the book, so I'm not going to go through this in detail, but just to point out that we are not, of course, the only group doing this at this point. There are a number of very prominent groups around the world now looking at this, and I'd have to say that although there are some differences in the details, this idea that inflammation, cytokines, epitope spreading precedes the diagnosis of rheumatoid arthritis is now a very well accepted phenomenon. The takeaway from the military cohort studies is that, again, within this particular cohort, that high-risk antibodies of anti-CCP and or tumor rheumatoid factors had a 74% sensitivity and very high specificity for future RA. I'll come back to the question of how long does it take to go from antibody positivity to active disease later. There were other antibody systems that we've looked at that were also present in this period, but they were much less sensitive, if you will, in terms of their presence, and that rheumatoid factors and ACPA still appeared to be the major early autoantibody systems, and that this concept of a gathering storm from multiple pathways is what we've really been trying to decipher ever since then. So the real question then becomes, how do you find individuals that you can identify the sites and mechanisms? And of course, to do this is not an easy problem. They don't walk into your clinic. You can't really go out and find people very easily who are antibody positive, who are in this interesting window. So a lot of what we've done over the last 15 years is figure out how to do it. And the goals, of course, to do this and the rationale for it, in some part, I think we have, I think, overcome initial resistance because, again, speaking to the generational aspect of this, when I was in training, I was told that autoantibodies were of interest but were not important unless you had a clinical disease. And I think that is something that's permeated my own history. Of course, we don't believe that anymore, but it has really stuck around that biomarkers, especially autoantibodies, may not actually be a relevant inclusion criteria, if you will. A lot of what I'm going to talk about for the first part of this is to try to debunk that particular idea. Now, the goals, of course, though, are to do the epidemiology, the genetics, to understand biomarker evolution, the natural history of this deep phenotyping, and I'll talk a lot about this as we go forward. And also then, as we understand more about this, and this will be the, really, I think, next generation to solve this, will be predictive models and autoimmunity and how you stop this. So how do we find them? We start with first-degree relatives of RA probands. Their lifetime risk is 3 to 5-fold higher than the general population. So that's one of our cohorts. Increasingly, we've gone into health fairs. Kevin Dean has pioneered this. We screen now about 7,000 individuals in health fairs in Colorado. A small percentage of these, about 2 or 3%, have active undiagnosed rheumatoid arthritis. About 5% of them have anti-CCP antibody elevations, so they can come out. We look at genetically enriched populations, and increasingly we're starting to get individuals who come to us who are referred for sort of aches and pains and nonspecific symptoms, come out of clinics, are CCP positive, but do not have any history or evidence of inflammatory arthritis. So out of this are the pools of individuals who are at risk, and of course the ones who are autoantibody positive we've proposed are at the highest risk and the ones that we really should be studying. And again, this has been a long-term commitment to take individuals in. We actually get samples from everyone, including all of the antibody-negative individuals. And we do a very standardized examination of these individuals. We get many samples and store them away. And then we can come back then later with a targeted hypothesis testing, and also, since this is largely a living biobank, we can ask individuals to come back and see whether or not they would be willing to do some of the more invasive procedures that we've undertaken. So the first thing that we had to convince ourselves of is that this antibody positivity was actually meaningful and was not simply a false positive outcome. And I think this was some of the more important ways that we started to look at this. First thing was to look at CCP2 status and ask, if you were negative or positive, how many of these peptide reactivities that Bill Robinson had defined were present in the CCP2 positive versus negative. And we were very pleased to see that there was a substantial elevation of the number, increase in the number of peptide specificities in a large number of these individuals. And they looked very similar, if you will, to those individuals undergoing epitope spreading in our military serum retrospective study. We also looked at elevations, so the likelihood of having elevations of cytokines, similar again, using the same assay as seen in the military study. We summed all the cytokines and demonstrated that those individuals, again, who are antibody positive, had elevations. That gave us an increasing sense that we could move ahead. And I'm now going to do a little bit of a segue as I talk about epidemiology, because as you start to come to this period, if somebody's going to ask you, I'm CCP2 positive, or I'm antibody positive, I have a family history, I don't have any symptoms, what can I do? So we'll sort of start the idea of the epidemiology of this with asking a question: which statements describe potentially modifiable factors in individuals who are high risk? There's nothing you can do to modify the risk. The genetic background drives all the risk. That you stop smoking and you take fish oil that's high in omega-3 fatty acids, and that'll definitely decrease your risk, or all of these are false. So please go ahead and answer this, and we'll come back to what I would propose as the right answer later. Very interesting. Okay, we'll come back to the answer at the end. Okay, so what did we learn from doing a very careful epidemiologic analysis driven by Joel Norris, who has studied type 1 diabetes for several decades now? and with using a similar kinds of approach. So if you look at first-degree relatives and you ask about all of the RA-related autoantibodies, that includes the different ways of measuring CCP antibodies, and actually in the at-risk population, CCP2, 3, and 3.1 will give you overlapping but not identical individuals. It's about 16%. If you add that and also look at rheumatoid factors. If you look at smoking, smoking is associated with an increased risk in oral contraceptive use, a decreased risk of being rheumatoid factor positive. That was one of our early findings, and again sort of helped to point us down in the direction that we thought we were going in the right pathway. We looked at vitamin D intake, that was not associated. We also looked at some other interesting things that have been published, looking at air pollution and cardiovascular imaging or lipid biomarkers, and saw no relationships. So smoking and oral contraceptive use were as one would see in a cohort of individuals with active disease. And we're now with the omega-3 fatty acid story. So this is one, again, I grew up in an era of time in which omega-3 fatty acids have had great interest and great lack of interest, and now we're sort of in a middle period right now. So I wasn't really clear or very happy when we got these results. But as I started to think about it, it became very apparent that this fits well within our emerging understanding of the disease. So on a science, kind of a high level here, omega-3 fatty acids, they have anti-inflammatory properties, and they're actively involved in the resolution of inflammation. Charlie Sirhan has a nice review from almost a decade ago now, showing how they enter into this resolvent pathway and are very much involved in downregulating many pathways in the inflammatory response. So they are shown to play very important roles. Now, omega-3s are of interest because you really have to have dietary sources of these to get very high levels. We can't endogenously synthesize them. ALA comes in, it can be elongated to EPA, DPA, and DHA. We'll focus on EPA and DHA. But only about 8 or 10% of the longer chain fatty acids, which are the ones that feed resolvins and are the most important, can be synthesized. So the major sources of this are fatty acids, are salmon or other fatty fish, or supplements or other dietary sources. So this was the first finding, was that if one looked at omega-3 fatty acid percentages in red cells, so why do we use red cells? So they are really a sum, if you will, of intake over the last several months. So they really are looking at a longer-term pool that really looks predominantly at intake, but also then is modified a bit by the genetics of the pathway. And one looked then at the odds ratio of having anti-CCP2 antibodies. And again, I'll just emphasize a couple of times, these are individuals who are antibody positive, don't have arthritis, who are in this at-risk cohorts, that one could see an inverse relationship here, such that the total and DHA and EPA plus DHA were substantially lower. If one asked about supplements, you saw the same pattern, that if you took supplements, you were much less likely of being anti-CCP2 positive. However, we did not, weren't able, and because of the variability in supplement quality, if you will, and content, we really think the majority of the evidence for this is in the biomarker. Surprisingly also, if you looked at this supplement use, but also it's reflected in the values also, there was an interesting shared epitope positive-negative relationship here, such that it was really in the individuals who were shared epitope positive that had this substantial reduction in rheumatoid, substantial reduction in rheumatoid factor. CCP2 went in the same direction, but was not statistically significant. So the way to put this together, and I'll come back to this, is that the mechanisms potentially affecting autoantibody production are dampening of inflammation through elaboration of resolvins. There is some interesting data on altering antigen presentation through lipid raft alterations or conformation of class II molecules that present the peptides, and also some interesting data on regulatory functions of CD4 T cells. But really, in this particular cohort, it's not one that we have been able yet to study, but we're very interested in doing that. If one kind of comes together and talks about environmental exposures, smoking, contraceptive use are the inverse of each other, and omega-3 fatty acids are quite interesting, to us at least. I'll come back to what we think could be useful here. Now, of course, out here, we don't see in this period of time everything else. Cardiovascular risk, we don't see some of the other air pollution, but the comorbidity, cardiovascular comorbidity, the absence of that is actually striking to us and at least suggests that if we can stop people from going from here to here, some of the comorbidities may in fact be ameliorated. The answers to this, the answer was in fact D as I see it. Certainly stopping smoking and taking fish oil, they won't definitely decrease everyone's risk. But we certainly hope that they will, but this is something that needs to be studied. Stopping smoking has been proposed as an important way to diminish risk. However, the Nurses' Health Study shows that it takes 20 years for you to lose that risk of developing rheumatoid arthritis if you do, in fact, stop smoking. So it is a modifiable risk factor, but it's one that really takes a long time to have an impact. Okay, so now the question that we'll start going into is that we reasoned that if we could identify individuals who are in this preclinical pathway because they had elevations of antibodies, peptide reactivity, cytokines and chemokines, and had some interesting epidemiologic exposures, we could take those individuals and phenotype them and figure out where rheumatoid arthritis started. Did it start somewhere else or not? And out of this has come our version, if you will, of the mucosal origins hypothesis. Now, the first question, of course, is, doesn't it just start in the joints and it's extremely asymptomatic for a very long period of time? So we were really indebted to studies by Paul Peter Tak and others who have looked at individuals who are autoantibody positive with arthralgia, looking at controls, looking at early RA, and have gone ahead and biopsied those individuals and don't see evidence, at least in the knees, of synovitis. We ourselves have MRI'd over 30 individuals in hands and feet, wrists of individuals who are antibody positive and don't see any evidence of synovitis either in the hands, wrists, or feet. So I think from a lot of different directions that one can't argue simply that the antibodies are being driven by subclinical synovitis, and that was the rationale that we had to go forward, and I think some of the data that I'll demonstrate to you will continue to point in this direction. Now, as we go through the mucosal hypothesis, let's see what your views of this are now. So which discoveries in the preclinical state by ourselves and others support the hypothesis of mucosal origins? Small airway disease and high-resolution CTs of these ACPA-positive individuals, the ability using new technologies, omics technologies, to identify a single bacteria strain is present in the GI tract of preclinical disease and drives this initial autoantibodies in arthritis. Or if you look at circulating B cells called plasmablasts, they encode IgA-producing antibodies that are largely mucosal. They're less mutated than their IgG-producing partners, and that's a feature of mucosal immune responses. So really pressing the immunology button here, and let's see what everybody thinks. That's very interesting too. Okay, we'll come back to the answer soon. I'd have to say that you're wrong. So that's okay, you know. All right, so why did we start looking at the lung? It seems, you know, in retrospect, it seems obvious, but I would have to say that this, again, was one of the studies that was funded initially in an autoimmune disease prevention center pilot mechanism whose major criteria for approval was that it was most likely, very likely to be false. So the hypothesis was that if you looked at individuals in their lungs who were antibody positive but had no lung symptoms or signs, that you would see something. But of course, if you now look in the retrospectoscope, several risk factors for RA are inhaled. Lung disease, of course, can be associated with elevations of RA-related autoantibodies and precede arthritis in some case series, and I'm sure everyone has seen these fascinating individuals. Active RA can be associated in eyeball with production of the antibodies in the lung, and structural abnormalities and inflammation and ACPA production are indeed present in early RA. But again, I would go back to the EULAR criteria slide and recall again that early RA is in fact late in the disease course during the preclinical period. So the question is how all of those fit back together. And of course, this now goes back to Kristen Demerel, who actually did this as a resident, working with Kevin Dean, looked at individuals who were autoantibody positive versus matched controls, and looked in a blinded fashion with CT radiologists, two of them at National Jewish, who validated each other's results and did this in a blinded fashion, and showed that small airway abnormalities, thickening, bronchiectasis, bronchiolitis, and air trapping were present in a much higher proportion of individuals who were autoantibody positive than negative, and this was true also of smokers. PFT exams were normal in these individuals. They did not have evidence or a history of lung disease. As we go forward, we're actually amazed at this whole story, and I'll try to get that across to you. So the p-values were there. Now, smoking, of course, always comes up in this, and I'm not going to emphasize this each time, but you know, this is largely in Colorado. The smoking prevalence in Colorado is much lower. It's one of the lowest in the United States. We see some evidence of an effect of smoking, but smoking, in our view, at least in Colorado, is not the major driver of the lung abnormalities. What we see is always in individuals who are not smokers. So I think that's an important point to make. I may not make it enough times, but I can come back and talk about it later. It's an example of one of the abnormal airway thickening seen in these particular individuals. So now we've got CT evidence. So what about other biomarkers? So Colorado also has a benefit. It's the Center for Cystic Fibrosis Studies in the United States, and all of the sputum that's collected by induced sputum in cystic fibrosis kids as part of big cohorts are studied in Colorado. So we were aware that one could do induced sputum in a very controlled manner, and that if you did that, you could in fact measure in the induced sputum of these individuals who are either controls, at risk, or RA. Now at risk is defined by largely by being a first-degree relative status. One could measure in the sputum CCP IgA CCP or IgG anti-CCP, and one could look then at individuals. And what was striking to us is that, yes, a subset of individuals who had active RA had locally identifiable autoantibodies that could have either been made locally or transferred from the blood into the sputum. But was of great interest also is that individuals who were in an at-risk pool also had elevations, predominantly in a relative sense of the IgA CCP antibodies. And if you looked at the black dots, those are individuals who were serologically positive, but the majority of these individuals were serologically negative and did not have circulating ACPA. One could also show that these were locally produced by ratios of specific to total immunoglobulin and albumin ratios. So these individuals who are at risk and who also have a higher prevalence of CT abnormalities also have locally produced autoantibodies. As we started to look further at the sputum of these individuals, we're starting to see additional very interesting relationships. And this it looks at the total cell count or the neutrophil count or the macrophage count. And if one looks at the ratio of anti-CCP antibodies of the IgA isotype, true also of G, there's a very direct relationship between the total cell count or neutrophil or macrophage cell count and the level of the antibodies themselves. If one asks another question, net formation, so nets of course are the physical bodies that are released from neutrophils when they're activated. The nets are presumed because they carry citrullinated target antigens, predominantly histones, to be perhaps a local driver or systemic driver of disease. One can also, with Mariana Kaplan, measure sputum net formation using a couple of different assays, and again you see a relationship between IgA or IgG antibodies and net formation. I'd say also we have started to look at the cells. And the neutrophils that are present in these individuals look remarkably activated. And the macrophages also look remarkably activated. And we're starting to look more further now into the cellular composition of these individuals. So again, what we're looking at are people who are CCP positive, do not have lung symptoms, do not have arthritis, but what they have in association with locally produced ACPA is evidence of inflammation based on cell counts and neutrophils. Okay, so another way that we've been attacking this problem is to look at peripheral blood cells. We've looked with Bill Robinson, who's a long-term terrific collaborator, and we've been looking at the B-cell response. I showed you some of the data with ACPAs, if you will. More recently, we've been looking at plasmablasts and memory B cells from at-risk individuals, and then taking them down a pathway that he laid out a couple of years ago in the initial study, in which you take peripheral blood from these individuals and controls, get single cells out, sort them into a single well. You can ID all the transcripts and genes from these individual wells, and then through pooling and sequencing and deconvolution and expression of recombinant antibodies and figuring out what they bind to, you can go back and say, what are the features of these plasmablasts, and then what do the plasmablasts in fact create? This was one of our first major findings, and that is Jen Kinslow, a postdoc in my lab, came in one day, and she said she'd been doing this, and it was really striking to her that it looked like the at-risk population who were antibody positive had a lot of IgA plasmablasts. And as this story evolved and we were able to quantitate it now, there's really a very striking finding in that if one looks at now the proportion of plasmablasts, this is not an increase, this is how they are proportional to each other, that individuals who are antibody positive had a striking elevation of IgA plasmablasts as compared even to early RA. So this is a biomarker phenotype that one would have missed by looking at early disease. You would have missed this earlier phenotype. G was inverse and M was not changed. And sort of by pattern recognition, these are normals, antibody positives. So what one sees is that about 2/3 of these have this abnormally elevated IgA plasmablast elevation. Looking serologically, this is the IgA ACPA response down here, and a substantial number of these individuals also have serum IgA antibodies to citrullinated targets. And to Bill and to other B-cell immunologists, what's kind of fascinating about some of these families is that one can sequence, this is a family in which one looks at each individual plasmablast by DNA sequence analysis and going back and looking at similarities. You can see how they evolved from as they branch off of individual trunks. And there were individual or groups of plasmablasts, if you will, that were both IgA and IgG that came out of the same family, and these are ones that one would presume are undergoing both a mucosal IgA response and either a local or systemic IgG response. So we are, of course, now in the middle. We've produced 100 of these and are now in the middle of analyzing them. Our presumption or hypothesis, I guess, is that these are making ACPA, and they're also making antibodies to very interesting antigens that would be present at mucosal surfaces. So why are we interested so much in IgA? It's the major immunoglobulin isoform. It's usually the trick question for students, is that since IgA is the lowest level in the serum, no one realizes that it's actually the most highly produced Ig form because it's all lost in the mucosal surfaces. Its primary role is protective. There are many different forms of it. It has a receptor that's involved in activation of innate immunity cells. It functions to enhance respiratory burst, really help us protect us from infection. And although tissue IgA plasmablasts are found in Peyer's patches and also in other areas of the bowel and draining lymph nodes, but they also circulate. And the understanding of what we've been able to detect are these circulating IgA plasmablasts. So what's the evidence now that RA is in fact initially a pulmonary or mucosal site disease? So we have the epidemiology, IgA antibodies. This has actually been reported by others. Also that there's an IgA predominance of ACPA and rheumatoid factor in the at-risk populations. These pulmonary high-resolution CT, local production, expansion of this, and then there's an association published that may reference one of the questions I asked of DMARD-naive early RA with dysbiosis. I would say what we see is a very different dysbiosis in our population. So that's okay. So what else do we see? Coming back to this question of, are these individuals immunologically normal, or are they in fact undergoing some kind of immune response that we should continue to look at? So a paper recently published with Yicheng Ho and Beth Carlson and others at the Brigham, I think has brought additional insight here. Yicheng Ho has a very interesting hypothesis about how PADs how PADs and citrullinated histones and various genotypes interact to result in changes in active disease patients with rheumatoid arthritis. He applied the same technology to our cohort and was able to see in the at-risk and early RA evidence of alterations of citrullinated H3, which I think is interesting, but probably more relevant, if you will, are looking at dysregulated phenotypes in CD4 positive T cells who were activated overnight. And what one could see is they were hypercitrullinated, as I just showed you, but they also produced higher levels of IL-17 and IL-2 and fewer Th2 cytokines. And they were also hypoglycolytic and hyperproliferative, the association due to low levels of these checkpoint molecules. So the kind of summary and I think important point here is there are a couple of them. One is, IL-17, as I understand, is not a great target in active disease. This is a very intriguing potential target in the at-risk population, especially given its very important role in mucosal immunity. The second is that these kinds of phenotypes have been described before, but by Connie Wyand and now others, in individuals who've had long-standing rheumatoid arthritis. And my at least sort of superficial belief had been that those were secondary to chronic inflammation, et cetera. But again, these individuals are not sick, they don't have arthritis, yet they still have this very pronounced evidence of what look to be metabolically driven changes. So I think another important clue. So coming back to this, so yes, the small airway disease is seen. There is not a single bacterial strain that's yet described. We're certainly hoping to find one. I think it's going to be a very complicated story because we're looking now at multiple mucosal surfaces, as I'll come back to. The plasmablasts are in fact elevated, but the point I didn't make is that they're also very highly mutated, similar to IgG. So that indicates they are really undergoing a very robust immune response against whatever antigen they're seeing. Okay, so what next? So that's sort of near the end of the comments about the science, and now it's somewhat philosophical. Those of you who watch Sherlock, like I did, my wife and my kids, know that there's sort of a deductive or an analytic approach that one can take, which we of course have been taking and are going to continue to take. But as Ian was so nicely laying out, and I'll just kind of mention, Watson and the sort of big data, big omics is also part of this process going forward. So I think a marrying, if you will, the two areas together is what we really need to do. So here are the active studies that are underway now in these individuals. Identifying antigens, both citrullinated, non-citrullinated, and pathogen-derived. Looking at other phenotypes using the tools that Ian so nicely laid out, epigenetics, metabolomics, looking additionally at cytokine dysregulation. We're looking at 6 mucosal sites now to try to understand this particular issue. I'll come back to that. What are the drivers of this? I think the mucosa is really something we need to understand in this early period. What's the relationship between local and systemic antibody responses? And then, of course, a real question is how you transition from this autoantibody positive circulating mucosal state to arthritis. The way that we look at this now is that you do have multiple sites. The evidence, I'll just sort of go back here to the lung just to mention this. Of course, in the at-risk population, about 23% at any one time and about 40% of at-risk individuals have ACPA at any one period of time. Now, none of those, not all of those are going to get RA. So that tells us that local ACPA production has to have some kind of, well, likely has some kind of local immunoregulatory or perhaps some kind of important protective benefit. That's also true of some of the other sites that we've started to look at. However this goes, and I'll come back to a hypothesis or some additional questions, you break tolerance at these sites initially. What we are able to detect in patients or in individuals who we study by research or come into our clinic is preclinical RA that's defined by systemic autoantibodies, and then you transition to disease. The way that we're thinking about the mucosa now has to do with sort of two general kinds of ways of thinking about it. One is normal homeostasis, is that ACPA are produced, in fact, locally and are part of homeostatic processes that either help to regulate what kind of bacteria or other life forms are present, and that they're actually, or in fact, that they're normally produced locally to help clear products of inflammation. NETs, if you will, are inflammation-related, citrullinated targets, citrullinated proteins have been known for a long time to be present at sites of inflammation. It may well be that local ACPA, in fact, are protective. The hypothesis that we think needs to be looked at. Another way of thinking about this is, regardless of what happens here, is that when you have a dysbiosis or inflammation, you start to make these ACPA, the B cells migrate to other sites, they switch to IgG isotype. T cells that are present here start targeting citrullinated proteins, start to circulate. And here the question is whether ACPA-coated bacteria, as part of this response, stimulate the mucosal immune cells, and ultimately this is unable to be controlled, and then you're on your way to disease. And the transition, I would just point you in the direction, I think it's a fascinating set of studies looking at, and are referenced here, looking at how you transition from ACPA to activating macrophages to convert to osteoclasts and in a pad-dependent manner make IL-8, which then starts this, this pain cycle, if you will, the arthralgia and pain cycle, and probably has several other local immune effects under the bone marrow, or in the bone marrow, and it's driving some of our interest now in doing bone marrow studies in our population. And I'll just finish now with a few comments about what we do to interrupt this process and what do we do here to keep things from going to this point of disease. So the general concepts are ones that are known to, I think, to all of us, in that in case control studies, these are pretty highly predictive. If you look at other studies, the positive predictive value goes down. So it's somewhere in between these two, likely due to populations, levels, ways that you measure these antibodies. So that's all very important. We have effects of genes and environment. There's a very interesting symptom scoring method that I'll just touch on briefly, just to remind you of that. Very interesting one that has been subsequently followed and utilized, and some interesting findings recently referenced to this original study. And then we're trying to build predictive models. And this is the biomarker environment and symptom predictive model that we've all read about. I'm not sure how many, I should have asked how many people follow this model. But it really helps with the scoring method. I think really very important initial study to look at, even though methotrexate in this and other cohorts has not been particularly good in delaying disease on all individuals. It's now understood that if you look at the ACPA positive population, or the ones that fulfill 2010 criteria, you do see a substantial protective effect. Another way to do this is to think about a two-step approach where you use highly predictive biomarkers, so you get an at-risk, then you use additional biomarkers to evaluate the timing. I didn't mention this, but certainly as you have more cytokines that are elevated, you are closer to onset. It's a real-life scenario, but importantly for all the stuff you need to have CAP-CLIA testing, and how well the cytokines fit under that is still, I think, in evolution. But what Kevin Dean has proposed, and as part of the STOP-RA trial, is to make this even simpler and to use a substantial elevation of CCP3. And then in the work that we've done, it's published and unpublished, it looks like 50% of those individuals within 3 years will develop classifiable RA simply by having a CCP3 of greater than 40 units that one measures at more than one single time point. There are, of course, as I said before, this is a rapidly evolving area. We talked a bit about smoking. I'll make a point about omega-3 again. A very interesting Prairie study, single dose of Rituxan, reported at EULAR to delay the onset by about 12 to 14 months. I forget the exact amount, but it was first proof of principle, if you will. The Epiprus study with abatacept, I understand fully enrolled, should be very interesting. Again, individuals who have multiple antibodies that clearly are statistically more likely to be close to onset or have very high anti-CCP. And then there's the STOP-RA trial. The interesting thing about omega-3, just to come back to that, is we've recently looked at this health fair cohort again, and individuals who come to see us who have prevalent inflammatory arthritis but don't meet criteria also have a relationship to omega-3 fatty acids, so that you're more likely to have this, to have prevalent inflammatory arthritis, and also trending toward incident inflammatory arthritis, the lower the omega-3 fatty acid levels are. So the final point is STOP-RA. This is the study strategy for the prevention of RA. Kevin Dean is the PI. Chris Strebick and I work with Kevin on this. CCP3 is the entry criteria. No history or exam of IA. Intervention is weight-based hydroxychloroquine for a year. We can come back later and talk about how we came up with this. This is the design, randomized, controlled, year of drug, 2 years of follow-up. Lots and lots of screening, and we're enrolling, and we're now above 30 individuals who are enrolled. And we have several individuals who've now converted to classified RA. Of course, don't know which group they came out of, but at least it looks like it's a study that's going to tell us something. We're using hydroxychloroquine. There are many different mechanisms whereby hydroxychloroquine can work. It's shown here. But I think the most important thing as we're getting into a new era of prevention in individuals who, in fact, don't have signs or symptoms of anything other than immune dysregulation is that it has an excellent safety profile. It's approved for RA, and it looks to have at least historical evidence of efficacy in palindromic rheumatism.